Imagine walking into a clinic feeling perfectly fine. You live an active lifestyle. You
Right.
keep an eye on your diet, you stay reasonably fit, and you're just there for a standard routine checkup.
Just a normal Tuesday?
Exactly. You sit down on the exam table expecting a quick conversation and a clean bill of health. But before drawing a single drop of blood, your doctor asks you to take off your shoes.
Yeah.
He takes one look, asks you a few pointed questions, and realizes you have been suffering from a silent, completely corrosive metabolic crisis for over 2 years.
It sounds extreme, but that isn't a hypothetical scenario.
Right.
That is the exact clinical reality documented by Dr. Richard Ben. He's a physician who has spent, over 2 decades observing the hidden pathology of metabolic disease.
And we're looking at his case study today.
We are, yeah. The patient in his primary case study was a 67-year-old man who thought he was in excellent health.
Right, he felt fine.
Totally fine. But when asked about his feet, the patient gave the response we see millions of people make every single day.
Mm-hmm.
He said, my feet have been a little numb lately, but I figured it was just getting older.
Just getting older, wow.
Right. But by the time the lab finally ran his blood work, his fasting blood sugar was 214.
Which is incredibly high.
It was massive. He was fully diabetic. And the structural damage to his body had been progressing entirely undetected for 24 months.
2 entire years of just invisible damage.
Exactly.
Which brings us to the mission of our deep dive today. As senior medical researchers looking at the longevity data, we are focusing our investigative lens entirely on the furthest extremities of the human body.
The feet.
The feet, yeah. We want to decode the body's hidden early warning system for elevated blood sugar. And we have a stack of clinical data here from the American Diabetes Association, the CDC, and leading medical journals.
And, the baseline numbers are just staggering.
They really are.
Right now, 1 in 5 Americans with diabetes.
Wait, 1 in 5?
1 in 5. That is over 8 million people who are walking around completely undiagnosed.
8 million adults just going to work, playing with their kids, living their lives.
While their blood sugar is actively physically dismantling their internal architecture.
It's a profound systemic tragedy.
It really is.
Yeah.
And that is the core conflict we have to unpack today. It's deeply concerning that modern medicine continues to rely so heavily on a retroactive blood test to catch this.
Right. We wait for a failure.
Exactly. We wait for a patient's lab value to cross a completely arbitrary numerical threshold on a piece of paper. Meanwhile, the actual biological damage.
The physical degradation of human tissue.
Yes, it's visibly manifesting months and often years earlier. A simple $12 blood test can catch this and completely alter the trajectory of someone's life.
But only if they know what biological markers weren't taking that test in the first place.
Precisely. If you don't know the signs, you don't take the test.
So we really need to trace this pathology chronologically, from the very first microscopic changes all the way to the point of systemic failure.
And the data shows us that this silent, invisible war always initiates at the exact same place.
Right, it doesn't start in the organs.
No, it starts in the peripheral nervous system, specifically in the feet.
I want to understand the biological geography here, though. Why does this devastating damage always begin at the furthest possible anatomical point from the heart?
Well, it comes down to the sheer physical vulnerability of our longest neural pathways.
Okay.
Think about the sciatic nerve, right? It originates in your lower back and branches all the way down your leg,
Down to the toes.
culminating in those microscopic nerve endings in the tips of your toes. It is the longest single continuous nerve structure in the human body.
So it's just a massive physical distance.
Exactly. And because of their extreme length, these peripheral nerves require a massive amount of metabolic energy just to maintain themselves.
Which makes them vulnerable.
Highly susceptible to any chemical imbalance in the bloodstream, yeah.
Which completely explains why the very first thing patients experience is that persistent tingling or numbness.
The pins and needles.
Right, that familiar pins and needles sensation in the toes. But, people dismiss it instantly.
Of course they do.
Think about your own daily routine. You sit on the couch, you cross your legs to read a book, your foot tingles when you stand up, and you just tell yourself, oh, my foot fell asleep.
Right.
So how is a patient supposed to differentiate between a harmless, temporary blocked circulation and the active degradation of their nerves?
It is all about the pattern. The pattern and the presence of a mechanical trigger.
A mechanical trigger.
Yeah, like if you sit on your foot and literally compress the nerve, the tingling is a logical, temporary response to physical pressure.
That makes sense.
But if you are lying in bed or sitting comfortably with your feet flat on the floor, and you suddenly feel that creeping fuzziness in your toes.
With no pressure at all.
Exactly. That is a massive red flag.
Because something else is causing it.
Right. To understand what is happening on a cellular level, Dr. Ben's clinical notes provide a brilliant analogy.
Let's hear it.
Imagine your peripheral nerves as living electrical wires. Every single one of these wires is encased in a protective plastic coating called the myelin sheath.
Like the rubber insulation on a power cord?
Exactly like that. That insulation is what allows the electrical signal from your brain to travel cleanly and instantly all the way down to your toe.
But when someone has chronically elevated blood glucose,
Yeah.
that excess sugar isn't just floating passively in the bloodstream waiting to be used for energy, is it?
No, it isn't. It becomes toxic.
Toxic.
It becomes a highly corrosive chemical environment. Yeah. The medical term is hyperglycemia-induced oxidative stress.
Which means what in plain English?
In plain English, the excess sugar acts like a slow-burning acid.
Acid. Wow.
It creates metabolic byproducts that literally begin to dissolve and eat through that protective myelin sheath.
They eat through the insulation.
Yes. The inner wire, the nerve axon itself, might still be intact, but without its insulation, the electrical signals start to short-circuit.
They scatter.
They become delayed, scattered, and fuzzy.
I want to pause and process the gravity of that biological mechanism.
It's heavy.
It really is. When a patient feels that recurring tingling in their toes,
Yeah.
they aren't just feeling a temporary lack of blood flow, they're consciously feeling the physical degradation of their neural architecture in real time.
That is the biological reality, yes.
They are feeling the protective coating of their nervous system being dissolved.
The tingling is the literal sensation of a short-circuiting nerve.
That is terrifying.
It is. And if we look at the American Diabetes Association data, nearly 50% of all people living with diabetes experience this peripheral neuropathy.
50%.
It is the single most common complication. Tens of millions of people are feeling this exact sensation tonight.
And they are writing it off as fatigue?
Fatigue or standing too long or just getting older.
But the clinical literature doesn't just leave us with the diagnosis, thankfully. It provides a highly specific protocol to counter this early stage damage.
It does.
For adults experiencing this, the mandate is a 20 to 30-minute purposeful walk every single day.
Yes, daily.
And the distinction here is important. We aren't talking about training for a marathon, right? Or doing high-intensity interval sprints.
No. We're talking about sustained rhythmic walking.
What's the mechanics of that? Why rhythmic walking?
The mechanics are crucial. When you engage in rhythmic walking, you are forcing the muscular contractions of your legs to manually pump oxygen-rich blood down into those furthest extremities.
So it's a physical flush.
Exactly. You are flushing out the toxic, stagnant environment around those nerve endings and delivering the oxygen and nutrients they desperately need to repair the myelin.
But that walk has to be paired with dietary changes, obviously.
Oh, an immediate, ruthless reduction in added dietary sugar.
Because otherwise it defeats the purpose.
Right. You cannot heal the nerve while actively pouring the corrosive acid back into the system. It just doesn't work.
Okay, so we've established that the nerves can lose their insulation and go numb.
Yeah.
But as I look through these medical journals, the pathology doesn't always stop at numbness. Sometimes it swings wildly in the opposite direction.
Into pain.
Severe pain. Patients don't report a gentle tingling. They report agonizing, violent stabbing pain.
Yes.
Sensations that their brain interprets as intense electric shocks or like hot needles being driven directly into the soles of their feet.
It's horrific.
Why would a dying nerve suddenly become hyperactive?
Because the nervous system is highly complex. And when subjected to a prolonged toxic environment, damaged tissue often becomes unstable.
Unstable?
We call this hyperactive nerve misfiring. Dr. Ben uses the analogy of a damaged car alarm to explain this to his patients, and it's honestly incredibly accurate.
Okay, a car alarm. How does that work?
Imagine a car alarm system that was damaged in a minor fender bender, right?
Right.
The impact didn't destroy the alarm itself. It broke the internal sensor.
Oh, I see.
So now at 2 in the morning, the alarm starts screaming at top volume. No one's breaking into the car. There is no external threat.
The alarm is just broken.
Yes, it's firing off desperate warnings because its internal wiring is compromised.
That is a fascinating way to understand it.
It makes perfect sense biologically.
The demyelinated nerves in the feet are the broken sensors. They are misfiring, sending these fabricated, high-alert pain signals up the spinal cord to the brain.
Exactly. even though absolutely nothing is physically attacking the foot at that moment.
And what makes this so heartbreaking is how patients, particularly the older demographics, try to manage it.
It's a tragedy of misdiagnosis.
We see a distinct pattern in the clinical research. A patient experiences this severe stabbing pain. They are conditioned to just, tough it out.
Right, the stoic generation.
So they go to their medicine cabinet, grab a handful of over-the-counter ibuprofen, and try to mask the agony.
But they do this for months.
Months. They convince themselves it's just a flare-up of arthritis,
Or plantar fasciitis, or an old sports injury acting up.
which is a catastrophic misunderstanding of pharmacology. I was looking into how NSAIDs like ibuprofen actually work.
Yeah, they aren't built for this.
Not at all. They are anti-inflammatory drugs designed to treat musculoskeletal inflammation by blocking specific enzymes,
Right.
but they are entirely biologically incapable of repairing a short-circuiting demyelinated nerve.
They do absolutely nothing to stop the sugar from destroying the nerve cell.
Nothing.
Taking ibuprofen for diabetic neuropathy is like putting on noise-canceling headphones to ignore the car alarm.
Wow.
You haven't fixed the wiring, you've just deafened yourself to the warning.
That is a perfect analogy. You're just ignoring the fire.
And a landmark study published in the New England Journal of Medicine confirmed that painful diabetic neuropathy afflicts approximately 25% of all people with diabetes.
25%. That is a massive demographic living with agonizing nerve pain.
Agonizing pain that is constantly, dangerously misdiagnosed by the patients themselves.
So what's the protocol in the literature for this hyperactive misfiring? It shifts away from just walking, right?
Yes, it focuses on deliberate neural stimulation.
Explain that.
Before a patient even puts weight on their feet in the morning, the recommendation is 5 minutes of dedicated foot and ankle stretches,
Just in bed.
right there in bed, flexing the feet, circling the ankles, gently pulling the toes back.
Why is that specific pre-weight-bearing movement so important?
Because you are demanding blood flow into the tissues and gently waking up the neural pathways before applying the massive mechanical stress of your entire body weight.
You're preparing the damaged wires for the load.
Exactly. Furthermore, the literature suggests a gentle 3-minute nightly massage.
Like deep tissue.
No, very light. Light circular strokes along the sole and up the ankle. This provides soothing, predictable sensory input to the hyperactive nerves.
To sort of calm the misfiring pathways before sleep.
Right, to give the sensor some normal data to process.
That actually brings up a really critical contradiction that I want to explore.
Sure.
If the sensory nerves are degrading to the point where they are sending entirely false pain signals to the brain,
Yeah.
what happens when the brain starts receiving completely fabricated environmental data, like temperature?
That is where it gets really disturbing.
Patients universally describe this next marker as a nighttime torment, the sensation of their souls physically burning.
Yes. This is a direct continuation of that sensory nerve damage.
So the foot isn't actually hot.
Not at all. The toxic, demyelinated nerve tissue is in such profound distress that it begins crying out, transmitting highly specific yet entirely incorrect heat signals.
So the brain receives data suggesting the foot is literally pressed against a hot stove.
Exactly. But the burning is not external. The fire is internal.
The raw sensation of the nerve endings actively dying.
It is the cell death signaling as heat.
And the rationalization loop happens again, doesn't it?
Always.
People assume the burning soles are just residual heat from a hot summer day, or the fatigue of standing on concrete floors for an 8-hour shift.
They'll soak their feet in ice water trying to stop it.
But the research tells us a totally different story. I have a study here from the journal Diabetes Care, and it reports that this specific phantom burning sensation is one of the absolute earliest symptoms of metabolic dysfunction.
The absolute earliest.
It physically presents 1 to 3 entire years before a formal diagnosis of type 2 diabetes is ever made on a blood test.
Let that sink in. 1 to 3 years.
It's a massive biological warning window.
And it is almost universally ignored by both patients and, unfortunately, many general practitioners.
Who just advise their patients to buy better shoes or orthotics.
Exactly. And we cannot ignore the psychological toll this takes.
The lack of sleep.
Right. This burning doesn't typically strike when you are walking around or distracted by your workday. It hits at night.
When you finally stop moving.
When you are lying in bed, in the dark, trying to rest, there is no ambient noise, no movement, no sensory distraction to pull your brain's attention away from the localized agony in your feet.
It isolates the patient.
It destroys their sleep architecture, and that lack of sleep, accelerates their overall physical decline.
So how do we combat a phantom fire? The clinical protocol here relies heavily on a two-pronged approach: hyperhydration and heavy dietary fiber.
Yes.
Let's break down the why behind that. The requirement is a strict minimum of 8 full glasses of water daily. I assume this isn't just about general health. This is specifically about the kidneys.
It is completely about the kidneys.
Yeah.
Your kidneys are the body's primary filtration system.
Right.
When there is an excess of corrosive glucose circulating in your blood, the kidneys need a high volume of fluid to effectively filter that toxic sugar load and flush it out through your urine.
So if you are dehydrated,
The blood becomes more viscous, the sugar concentration remains exceptionally high.
and the nerves just continue to bathe in that acidic environment.
Exactly. You have to dilute the toxin.
And the second prong is the introduction of heavy dietary fiber, specifically vegetables, legumes, and oats, into every single meal.
Fiber is critical.
From a mechanical standpoint, fiber acts as a physical barrier in the gut, right?
Yes, it slows down the gastrointestinal absorption of sugar into the bloodstream.
So you aren't just feeding your microbiome, you are physically blunting the rapid glucose spikes that are actively torturing those damaged nerves.
You're preventing the spikes that cause the burning.
Okay, so while the sensory nerves are projecting this phantom heat, an even more dangerous structural collapse is occurring silently alongside it.
Right.
We have to look at the autonomic nervous system.
This is a huge piece of the puzzle.
Most people understand that nerves control movement and feeling. Like, I tell my hand to move, it moves. I touch a hot stove, I feel pain.
Sensory and motor nerves.
But what they completely fail to realize is that the autonomic nerves control the involuntary maintenance systems we never have to consciously think about,
The background processes.
like regulating our heart rate. Or, in the case of the feet, sweat regulation and internal tissue hydration,
Yes.
which leads us to a highly visible yet completely misunderstood marker: severe heel cracking.
This is one that fools so many people.
Right. When chronic high blood sugar attacks these autonomic nerves in the feet, the localized sweat glands literally fail.
They shut down entirely.
The foot loses its biological ability to produce natural moisture from the inside out.
I want to use an analogy I found in the clinical notes that really made this click for me.
Please.
Think of the thick skin on your heel as a fortified, sealed brick wall.
Okay, brick wall.
The high blood sugar systematically destroys the autonomic nerves. And that destruction acts exactly like the mortar crumbling away between the bricks.
Oh, wow.
Without the mortar, the structural integrity of the wall vanishes. The simple pressure of just walking splits the wall wide open.
And this is where I have to be incredibly authoritative with anyone listening. When you look down and see deep, persistent cracks in your heels, you are not looking at a dermatological issue. You are looking at a severe neurological deficit.
It is a nerve problem, not a skin problem.
Patients will spend years, literally years, buying expensive pumice stones, filing their heels, and applying thick lotions to skin that is cracking so deeply it is physically bleeding into their socks.
It's awful. They believe they just have, dry skin from the winter weather.
They are fundamentally misunderstanding the pathology.
It's a terrifying misunderstanding because those deep fissures aren't just cosmetic annoyances.
No.
They are gaping, open doors for massive bacterial infections.
The protective barrier of the body has been physically breached.
And remember, this is happening in a lower extremity that is already suffering from nerve damage and compromised blood flow.
Right, the healing systems are already offline.
Exactly. An opportunistic infection entering through a cracked heel can escalate into a limb-threatening crisis in a matter of days.
Which is why the preventative protocol requires daily, targeted maintenance. Nightly moisturizing of the sole and the heel is mandatory.
You have to use a high-quality lotion or pure, unrefined coconut oil.
To artificially provide the barrier protection that your dead autonomic nerves can no longer supply.
Yes, but, and this is a critical clinical warning, you must never, under any circumstances, apply that moisturizer between your toes.
I saw that in the data. Why is that? If the foot is dry, shouldn't we moisturize the whole thing?
It comes down to the structural anatomy of the foot. The space between the toes creates a tight, dark, naturally warm environment.
Right.
If you introduce external moisture there, it becomes trapped against the skin. You're essentially creating a perfect humid incubator for aggressive fungal infections.
Oh, man.
And because the diabetic immune system is already heavily compromised, the body will struggle immensely to fight off a fungal infection that starts between the toes and invades the nail beds.
So moisture on the heel, dry between the toes.
Strictly.
This mechanism of infection and the body's inability to heal it really forces us to look at the next major system failure.
Vascular system.
We've established that the peripheral nerves are dying, but we have to look deeper and ask why they are dying in the first place.
Yeah.
They are suffocating because their vital biological supply lines have been choked off. The pathology moves from the nervous system into the circulatory system. We are looking at an active vascular famine.
This systemic starvation first presents as a symptom people joke about constantly.
Cold feet.
Cold feet, yeah.
Yeah.
It is the clinical hallmark of peripheral artery disease.
Soupy-aid.
Patients laugh about needing electric blankets in the middle of July, or wearing thick wool socks to bed while their partner is sweating.
But the biological reality driving that temperature drop is deeply concerning.
Chronic elevated blood sugar fundamentally alters the physical structure of your blood vessels.
I was reading about endothelial dysfunction in the journals. The inner lining of the blood vessels, the endothelium, is supposed to be smooth and flexible.
Right. It expands and contracts.
But the high glucose levels chemically cross-link with proteins. It physically thickens and stiffens the vessel walls, narrowing the pathway for blood to travel.
The process is called glycation.
Glycation.
To visualize this circulatory failure, we can look at the analogy of a home heating system.
Okay.
Imagine a large house in the dead of winter. The furnace in your basement is working perfectly. That furnace is your heart. It is pumping out heat.
Right.
But if the pipes running to the furthest guest room at the very end of the house have been severely narrowed by decades of mineral buildup, the hot water simply cannot reach the end of the line.
It just can't get there.
It doesn't matter how hard the furnace works or how high you turn up the thermostat. The physical delivery mechanism is choked off. That furthest room stays freezing cold.
And in the human body, that freezing room is your feet.
Exactly.
The clinical stakes here are massive. According to the American Heart Association, peripheral artery disease currently affects over 8 million Americans.
8 million.
And the primary driving risk factor for developing PAD, it's diabetes. The high blood sugar is literally cementing the biological pipes shut.
The intervention protocol for this specific vascular narrowing is mechanical and non-negotiable.
Back to the walk.
It circles back to that daily 30-minute purposeful walk, yes, but with a specific focus on arm swinging and rhythmic pacing.
So we are not talking about a leisurely stroll through the aisles of a grocery store.
No. We are talking about utilizing continuous cardiovascular demand to literally force warm, oxygenated blood down into the lower legs against the resistance of those narrowed vessels.
The physical pressure is the medicine.
Yes. That physical pressure strengthens the vessel walls. It promotes the release of nitric oxide to dilate the arteries, and it forces the body to optimize whatever circulatory pathways remain open.
But what happens when that vascular famine progresses? When the blood flow becomes so restricted that the localized starvation becomes visible to the naked eye?
It's terrifying. The clinical data points to a profound oxygen crisis in the tissue, presenting as unexplainable discoloration.
Discoloration. Let's dig into that.
Well, the lower legs and the feet sit at the very end of the body's longest biological delivery route. They are the furthest from the heart, and they have to constantly fight against gravity for venous return.
Right, getting the blood back up.
When the blood delivery trucks, the red blood cells carrying life-sustaining oxygen and nutrients, fail to arrive because the vascular roads are narrowed, the tissue begins to literally suffocate.
And the visual evidence of this suffocation is undeniable once you know what to look for. The skin itself begins to thin out.
It loses its structure.
It becomes highly fragile, almost translucent like tissue paper. And because the tissue is starved of highly oxygenated, bright red blood, the skin drastically changes color.
Yes.
You will see it turn unnaturally dark, deep red, or take on a terrifying bluish or purple tint, particularly pooling around the ankles.
And again, the rationalization kicks in. Patients will write this off as sun damage.
Or they assume it's just the natural coloring of their skin changing as they age, or maybe an issue with their circulation from sitting too long.
But we have to highlight a vital study published in the Journal of the American Academy of Dermatology.
What did they find?
Their researchers found that these specific visual skin changes, this vascular discoloration around the ankles, are biologically detectable an astonishing 18 months prior to a formal clinical diagnosis of diabetes.
18 months.
A year and a half.
The skin is acting as a massive, highly visible distress flag for a year and a half.
It is screaming that it is suffocating.
And the medical establishment is largely walking right past it because it doesn't hurt and it isn't a lab value on a chart.
It's a huge blind spot. The protocol to combat this localized pooling is simple, but it must be done daily. 5 minutes of deliberate ankle circles and toe raises.
What does that do?
You are mechanically engaging the calf muscle pump. Your calf muscle acts as a secondary heart for your lower extremities.
Oh, I see.
When you flex it, it squeezes the deep veins and manually forces the deoxygenated, pooled blood back up the leg against gravity toward the heart so it can be reoxygenated.
And as this oxygen crisis deepens, the body is forced to make brutal, calculated decisions about what tissue gets to survive.
Survival mode.
Which leads us to a marker that is so subtle, most people miss it entirely for years: the absence of hair on the toes and lower legs.
It is the physical manifestation of follicle starvation.
Right.
We know that hair follicles are highly metabolically active structures. They require a massive, steady, uninterrupted supply of blood, oxygen, and nutrients to produce hair.
So when the blood vessels narrow to a critical threshold,
The body recognizes a supply shortage. The follicles simply starve, they slowly shut down, and they stop producing hair entirely.
I want to make sure I understand the mechanism here. Is it clinically accurate to view this localized hair loss as a biological triage system?
Triage is the perfect word.
The body is essentially suffocating under the restriction of these narrowed vessels, so it begins systematically shutting down non-essential biological functions like growing hair on the big toe, in a desperate attempt to preserve whatever pathetic trickle of blood is left for the vital, life-sustaining skin and muscle tissues.
That is precisely the biological reality. Think of it like small peripheral plants at the very edge of a large garden where the main irrigation pipe has been severely blocked.
Right.
Those peripheral plants don't turn brown and die overnight. They just gradually stop growing.
The water doesn't reach them.
The absence of growth is the ecosystem sending a clear message that the life-sustaining water is gone.
And there's data to back this up.
Oh, yes. The peer-reviewed literature in the Diabetes, Obesity, and Metabolism Journal correlates this exact mechanism. It proves that hair loss on the lower extremities is a direct, statistically significant indicator of peripheral vascular disease.
It is so subtle, though. A patient might never notice that the hair on their lower shins vanished over the course of 5 years.
They really wouldn't.
But if you look down at your toes and your lower legs right now and notice that the hair has inexplicably vanished, leaving perfectly smooth, shiny skin, the protocol shifts immediately.
Drastically.
This isn't something you manage with a walk. This requires immediate clinical intervention. You do not wait until your annual physical next year. You schedule a $12 fasting blood glucose test this week.
This week, not next month.
Because if your body is actively amputating its own biological functions to save blood, you are completely out of time for a wait-and-see approach.
And that urgency is completely justified. Because if the warnings are ignored, we enter the most critical, highly dangerous phase of our investigation.
Phase 4.
We move from the localized tissue starvation of the feet into a terrifying whole-body systemic failure.
This systemic failure often presents visually through a mechanism that seems totally unrelated to blood sugar at first glance: pitting edema.
Yes.
Massive, unexplainable swelling in the feet and ankles. And this is a direct indicator of severe kidney distress.
We have to understand the sheer volume of blood the kidneys process. Every single drop of blood in your body passes through your renal system constantly to be filtered and cleaned.
Millions of times.
Inside your kidneys are millions of microscopic filters called nephrons. Years of chronically elevated glucose act like chemical sandpaper on these delicate filtration membranes.
Chemical sandpaper.
When those microscopic filters are damaged and clogged by the toxic sugar load, the entire fluid management system of your body backs up.
It's a plumbing issue on a biological scale.
Yeah.
And because of basic physics, specifically gravity, that excess fluid has nowhere to go but downward.
It pools.
It pulls heavily, pooling in the lowest anatomical points of the body. Patients will take off their shoes at the end of the day and find deep, alarming sock marks pressed deep into their swollen flesh.
And what do they assume?
They assume they just stood too long or had too much salt at lunch.
But we are looking at a fundamental breakdown of internal fluid dynamics. The diagnostic test for this is something every individual can do at home, and the results are often quite shocking to the patient.
It is called testing for pitting edema. You take your thumb and you press it firmly into the swollen tissue of your ankle, right against the bone. In a healthy ankle, the fluid displaces for a fraction of a second, and the skin springs back immediately when you remove your thumb.
Instantly.
But in pitting edema, the fluid is so dense and the biological return mechanism is so broken, you pull your thumb away and you are left staring at a deep indentation,
A physical pit.
a literal pit remaining perfectly molded in your flesh for several seconds. The tissue physically cannot rebound.
The clinical stakes regarding this specific type of edema are immense. Data from the National Kidney Foundation states that 1 in 3 diabetic adults currently have some form of kidney disease.
I need to pause on that. 1 in 3.
1 in 3. And lower extremity edema, this exact pooling of fluid we are describing, is frequently the very first visible physical warning that the renal system is quietly failing.
The protocol to manage this requires both mechanical and dietary intervention immediately. First, you must physically fight gravity. You must elevate your feet above the level of your heart whenever you are resting on the couch or sleeping. You have to give that trapped fluid a downhill slope to drain back into the central circulatory system.
You have to help the body move the fluid.
But more importantly, you must drastically, ruthlessly reduce your sodium intake.
Sodium acts as a chemical sponge in the bloodstream. It forces your body to retain water, which violently exacerbates the edema and puts even more pressure on your failing kidneys.
So you have to check labels.
You must scrutinize the labels on every canned, processed, and boxed food you consume, because hidden sodium is actively drowning your lower extremities from the inside out.
And if the edema, the vascular starvation, and the nerve damage are allowed to progress unchecked, we arrive at the catastrophic zenith of this pathological cascade.
The final stage.
These are the wounds that simply will not close. We are talking about the formation of diabetic foot ulcers.
The biological mechanism here is the devastating culmination of everything we've discussed in this entire deep dive. We go back to the kinked garden hose scenario. A patient gets a tiny, seemingly insignificant blister from wearing a new, tight pair of shoes.
Very common.
In a healthy body, that blister heals in 3 days. The blood rushes to the site, carrying an army of white blood cells to fight infection, oxygen to fuel cellular repair, and nutrients to rebuild the tissue.
It's an automated response.
But in the diabetic foot, those narrowed, stiffened, calcified blood vessels are the kinked hose. The healing ingredients exist in the bloodstream, but they physically cannot reach the site of the wound.
The immune system is completely cut off from the battlefield.
And the clinical outcome of this restriction is nothing short of tragic. The microscopic wound sits there, completely open, unguarded, and vulnerable.
The autonomic nerves have stopped providing moisture, so the surrounding skin is cracked and brittle.
Yes.
The sensory nerves are completely deadened, so the patient doesn't even feel the wound getting deeper.
They don't even know it's there.
And because the white blood cells cannot reach the tissue, opportunistic bacteria from the floor or a sock invade the open blister. The localized infection rapidly deepens, silently eating through the subcutaneous fat, invading the underlying muscle, and eventually reaching the bone itself.
That's gangrene.
I have to stop us for a second to really reflect on the scale of this.
It's hard to grasp.
We are talking about a microscopic shoe blister, a tiny friction wound that someone ignored on a Tuesday.
Right.
And because their vascular pathways were silently choked off by high blood sugar, combined with a medical delay of just a few mere weeks, that ignored blister escalates into gangrene.
And the outcome of that is grim.
The Centers for Disease Control reports that this exact, precise biological mechanism leads to over 100,000 non-traumatic lower limb amputations in the United States every single year.
I know. 100,000 Americans are having their feet or legs surgically removed every 12 months.
I'm sorry, 100,000.
Every single year.
Because a simple blood test wasn't ordered and a highly visible biological warning sign was ignored, it is an incomprehensible failure of preventative medicine.
Which is why the absolute protocol here is the 48-hour rule.
Let's explain that.
Every single night, when you take off your socks, you must physically inspect your feet. You look between the toes, you look at the heels, you check the soles.
Visually inspect them.
If you find any broken skin, any cut, any blister, you clean it immediately with mild soap, you apply an antiseptic, and you cover it. And here is the rule. If that wound has not visibly, definitively improved in 48 hours,
You do not wait a week.
you do not try another over-the-counter cream. You go to a clinic or your doctor immediately. You treat a non-healing wound on a diabetic foot as a severe medical emergency.
We have meticulously tracked the pathological destruction today, from the very first short-circuiting nerve tingling in the toe, all the way to the systemic collapse requiring amputation.
It's a clear chronological path.
And as we pull all of these clinical threads together, the absolute overarching theme of this deep dive is clear. Your body is not failing randomly.
It's not.
It is not secretly plotting against you in the dark. Your biological architecture is practically screaming for help through distinct, highly visible, and deeply specific physiological alarms.
The tingling, the nighttime burning, the severe heel cracking, the unexplainable coldness, the discoloration of the skin, the vanished hair, the pitting edema, the stabbing nerve pain, and the wound that refuses to close.
These are not random inconveniences.
They are not just the cost of getting older. They are a chronological roadmap of metabolic failure laid out directly on your skin.
And so we want to issue an urgent, non-negotiable call to action to every single person listening to this deep dive. Tonight, when you prepare for bed, I am asking you to take exactly 30 seconds.
30 seconds. That's it.
Sit down on the edge of your bed and actually look at your feet. Check the color of the skin around your ankles. Feel the toes for hidden numbness. Look for absent hair on the shins or a slow healing blister on the heel.
Catching these biological signals early means your independence, your cardiovascular health, and your physical mobility can be entirely preserved through simple, manageable dietary changes and dedicated daily walks.
Do not let ignoring a simple signal cost you your mobility.
The clinical data proves that the power to halt this progression rests almost entirely in your hands. But it requires you to be an active, observant participant in your own biology. You must look for the signals your body is sending.
I want to leave you with a final, haunting medical question to ponder long after this discussion ends.
Okay.
We have just spent an hour proving that our human biology possesses this incredibly intricate, highly visible, and desperately loud early warning system encoded into the furthest, most remote extremities of our bodies.
Yeah.
If the body is willing to signal systemic failure this loudly through a numb toe or a hairless shin, what other vital, silent distress signals is the modern adult currently writing off as just getting older or blindly masking with a handful of over-the-counter painkillers?